prescribed azithromycin, amoxil and a couple of other antibiotics, and they were looked at very large sample populations, and they found that if a person had a high cardiac risk or had pre-existing arrhythmias, then there was a definite increased risk of sudden cardiac death if you prescribe azithromycin. So we're just working through this paper now. The FDA in the US is away coming up with a position paper on it that they haven't come up with yet. The cardiologists we've been in touch with in Adelaide are advising that we can continue to prescribe it, but not to the very high cardiac risk patients, and certainly not to any who've had a history of arrhythmia. So that's something very important you need to bear in mind, that we've only just found out about in the last couple of months. So they're definitely not lollies, and you have to weigh everything up when you prescribe the medication. Right, well, now I'm going to show you some cases which I hope you'll find very interesting. They are cases of patients that I've treated since about 2008 using azithromycin, and this drug has absolutely revolutionised my periodontal practice. I've been able to manage patients in a completely different way since the use of this drug, and this experience is in common with most of my periodontal colleagues around Australia.
Back Mount Isa, imagination reality. The Mount Isa campus, known as the Centre for Rural and Remote Health, has been established in line with the Commonwealth Department of Health and Aged Care's program to establish university departments of rural and remote health. The Mount Isa Centre is already producing excellent outcomes for medical and allied health students from across Australia and overseas. The centre offers a range of professional education and training and has been established with very specific goals.
Yeah.
These include the...
Thanks. Oh, thanks for waiting. Thanks. So the first case I'll show you is one that I'm actually treating at the moment. I first saw this person in March this year. He was a male, aged 20, and he'd be classified now as aggressive periodontitis, but he's a classic juvenile periodontitis. Okay. So very localised periodontitis here, here, and here, predominantly. When he first came in, he had a very, very large abscess, which could have been a dental abscess or a periodontal abscess with pus pouring out of this area. Now, I won't show you his whole mouth, but I'll just focus on this area because I've got quite a lot of other cases that I'd like to show you. As I go through these slides, perhaps have a look at this area and this area here, because this, the 1-3, because this is a mirror shot here, also had a very deep periodontal defect. Okay, a week after taking azithromycin as the only treatment, because he was acute, this abscess had dramatically subsided. And you can see already that there's been quite a lot of changes in the periodontal tissues in this area and this area. So now you might expect to see that with, a combination of amoxil and flagyl, which might be the alternative treatment for this person, but I'm not sure. At 2 weeks, he's starting to look almost, well, not normal, but he's, the inflammation is going away. This is consistent with what I see regularly with patients who have, very inflammatory disease. You can see the tissues remodelling here. 2 months, he's looking pretty good. And all I've done periodontally is subgingival debridement. So I've given him LA in those deep defects. I haven't done flaps, nothing. Just deep debridement under LA and taught him how to clean his teeth. 3 months. So I think that's the latest one I've got. I just saw him a week before I came up here. And again, you can see the tissues are starting to remodel around this area, in here and here. So the pocket depths are right down. I think we're going to save his teeth, all of his teeth, against the odds. And I don't think he's going to require periodontal surgery. So I'm seeing him regularly for cleaning out the pockets that are remaining and so forth. I've got a question here, but...
He hasn't had a second course?
No second course, no. No, a single course, yeah. Okay, so, and I thought, well, why not take a couple of radiographs to see. Now, unfortunately, I don't have PAs of the initial, and I know it's not really valid to compare OPGs and PAs, but what I'm seeing here is consistent with what I'm seeing clinically, that this is starting to heal, and I think there's bone starting to form in these areas here compared to here. All right, so I'm quite confident that in another year this guy will have bone in these areas around here. It won't regenerate all the way up to here, but it will consolidate around the mesial root here, and this will fill in up to about here. Now that's a pretty good result for a fairly minimal periodontal intervention, I think. Now this is probably one of the most challenging cases I've had in recent times. So this was a female, as you can see there, not well-controlled diabetes, but a non-smoker, and she was advised to have a full mouth clearance. Now I have to... okay, so this was her at her initial consult, and this is all calculus here. This is a really thin, the hardest calculus you've ever met in your life, and it extends all the way down the root surface. You can see the amount of inflammation. She's a basket case, periodontally. Unfortunately, the OPG is not one of the world of OPG's greatest. But you can see the extent of the periodontal bone loss. I had to root resect this one and just splint the crown to the adjacent teeth. I splintered these. There's almost no bone around these upper incisors. Eventually she lost this one here. But what I want to show you is what happened since February 2010 to this person. So I made a movie for you, and there's a couple of rules when you watch the movie. First of all, don't worry about the supragingival calculus. Whenever the patients come in for their next treatment, I take my photos. I don't wait to clean them up and make them look pretty for my photos. So they're just as they come in through the door, they sit down, wham, they have photos every time they come. So every time this patient comes, she's got loads of supragingival calculus. Every time she comes, I take it away again. But what I'd like you to focus on is the gingival tissues around a few teeth, because otherwise there's too much going on. It's a time-lapse thing. And so if you focus on one area, and I suggest this upper right area is as good as any other. So they're the rules for watching the movie. Okay, so that's obviously back to the beginning. And so what that shows is, so that's her more or less now. Or what that shows is this happens over a long period of time. This healing, periodontal healing, is it doesn't happen over 4 or 5 weeks, it happens over years. And the longer people are away from that initial course of azithromycin, the better they get. So each time I see her, she gets better and better and better. And all I'm doing is periodontal maintenance. So I'll just go through that, what I'm actually doing. So this was the initial consult. That's what she looked like 12 months later. You can see how little bone is left around these upper incisors. But you can also see there's been some consolidation of bone, even though you can't compare this initial rather dodgy OPG compared to that one. But what I'm seeing clinically is there's no pockets anymore. She does not have any pockets. She does not have any mobility anymore. No, they were just about ready to pick out. Yeah. So what I want to do is take you through what my treatment and what actually happened. And so this is the gamut of data I have for this patient. And so at that initial appointment, I said to her, look, you'll probably lose most of your teeth, but we can try. And she was pretty keen to turn things around. So she had an initial dose of azithromycin on day 1, and then these points in time represent me getting in there and trying to clean her up, trying to get rid of this horrible sticky calculus. She was one of the rare patients that I've ever given 2 courses of azithromycin to, because by May she still had pus coming out of some of her pockets. So she had another course of azithromycin then, and then she had a few more visits where I did subgingival scaling to try to get down in the deep pockets and really work hard at it. After that, she had maintenance. So these are, every 3 months or so she'd come back, I'd clean her up, do the usual maintenance thing. No periodontal surgery, no advanced periodontics at all. Now, what I want to show though is in this particular case, which was probably one of the most advanced cases I've used azithromycin in, this is actually what happened in terms of the healing response. So by 3 weeks, all the bleeding on brushing, which was her main symptom, stopped. But it wasn't until about September or October, after starting in February, that I started noticing there was an incredible difference in the quality of the tissues. And I think it took that long for whatever the healing aspect of azithro is to kick in. So if we look at that clinically, she was still having pus coming out of her tissues here. And you could say, oh, well, that's because, you're a dodo and you didn't clean her up properly, But I was getting in there and cleaning up the plaque, subgingival plaque, until my fingers were falling off with this lady. But you can see the difference by October 2010. There's, tissues had started to respond and to heal up really well. And the other really interesting part of this was, here we are in about October 2010, and you can see there's still some subgingival calculus because I haven't removed it. Now, I didn't see that lady again until February of the next year, and in that time I didn't see her. And what this is telling us is there's still healing going on, even though there's subgingival calculus around here, because the tissues are still responding somehow to the azithromycin, because it's probably still hanging around in the tissues. Now, I've probably rescued this lady's teeth, and, all I see is things getting better and better and better each time I see her. I wouldn't even think about another course of azithro unless it all went pear-shaped. But it's just getting better and better each time I see her, and there is no mobility anymore and no pocketing. The other absolute bonus that we've seen is that in some cases we do get some bone regeneration. just by using azithromycin and conventional non-surgical periodontal treatment. So the cases I'll show you here did not have surgery, they didn't have GTR or Emdogain or anything like that. So this was one of the first cases I'd used azithro on. Again, anyone in their right mind would say, okay, so when are we making the full upper and full lower denture? You know, it's all over Red Rover for this poor lady. And I had no idea really what we were going to do with her, because she's very, very difficult periodontally. She was adamant she wanted to keep her teeth. I won't go into the whys and wherefores of this case, but she had a single course of azithromycin in June 2009, and the next OPG was taken 6 months later. Okay, so you can see that. I'll go back to the initial one. When I go back to the initial one, just have a look at the furcation defects that are present. Have a look at this area here. Have a look at this area here. She's still got all her teeth, even their 8s. And she's still got all her teeth now in 2012. And she's getting better and better and better. So if I go back, you see those really hopeless periodontal lesions all through here, all through here. And, you know, that's pretty good. I'd be pretty good if that happened after periodontal surgery and guided tissue regeneration and all that sort of stuff. Another case, severe localised periodontitis around this lateral incisor. She just happened to want a perio exam. She didn't have any symptoms, and we found this rather large localised defect. Now, I sent her off to the dental hygienist, and she came back 6 months later like that. So you can see I'm pressing pretty hard on the probe here because the tissues are blanching. I'm really trying to get into this pocket, but there's no pocket there anymore. And there's been some sort of, not fill, but, you know, improvement in the bone here. If it was your tooth, I think you'd rather have that than that. But it's not going to come back down here. We still don't know how to do that. And that was with my dental hygienist. This is a very interesting series of OPGs showing bone regeneration. This was a colleague of mine's series of cases, and he'd basically written this patient off periodontally in terms of his molars. So all this patient